Dear guests, please welcome to the Asian Society of Pediatric Anesthesiologists FLEX webinar series, which is scheduled for every third Sunday of every month. Today, we are discussing and talking about a very current and very interesting topic, which is POCUS. The incorporation of point-of-care ultrasound has represented a transformative change in clinical practice, challenging the traditional diagnostic and procedural art of medicine. The new clinical tool almost displaced in some way the classical stethoscope. We have today very precious speakers from all around the world. We have 1 hour and the next half an hour we'll have the questions and answers. Before beginning, I just want to remind some small housekeeping rules. We have the speakers, and then at the end of at the end of all talks, we will take the questions and answers. You can write the questions, your questions or comments to the questions and answers part. Please do not forget that chat function or the raise hand function is disabled. Our moderators will highlight your questions to the appropriate speaker during panel discussion, and you will be answered during the speech as well. But all the questions will be answered wordly at the end of the speech. If you miss something during the webinar, you can follow the webinar in our Facebook or in our website or YouTube page as well. Thank you for attending. And also, now I want to sorry. At the end of the webinar, you will be sent a post-webinar survey. The post-webinar survey link will be available immediately after the webinar ends, and post-webinar follow-up email will be sent tomorrow at 5 p.m. Please ensure that you have correctly keyed in your full name and email. Now I want to introduce you our moderator, Dr. Norifimo Kuratani from Saitama Children's Medical Center, Saitama, Japan. And he will be moderating our webinar with Dr. Teresita Batenes. She is from Ramon Magsaysay Memorial Medical Center, Philippines. Thank you, Dr. Nori.
Okay. Hello, let's start today's webinar. My name is Dr. Nori Kuratani from Japan. I'll be one of the moderators today. So Dr. Amit, can you show your introductory slide? So I would like to welcome first speaker, Dr. Amit Dixit. Dr. Amit is a consultant anesthetist at Ruby Hall Clinic, Pune, India. And he will speak about the basics in lung ultrasound. Okay, so Dr. Amit, please start your lecture.
Yes, thank you, Dr. Nori. Dr. Satish, can I have the polling questions, please? Yeah, so today we'll be having 4 polling questions before the start of my lecture. So there are 4 questions and you have 30 seconds to answer them. So the first question is, which of the following is not a defining characteristic of B lines? B lines move with lung sliding. B lines are ray-like hyperechoic vertical discrete lines. B lines emanate start from pleural lines, never above the pleural lines, and B lines attenuate after 1 to 3 centimeters. Second question, please. Yeah. So this was first question. Now we have second question. Dr. Satish, may I have the second question, please? So the second question is, all are normal sonographic findings of lung except A lines, B lines, Z lines, and curtain sign. So you have 30 seconds to answer this question. We'll see the answers at the end of my presentation. All right. So may I have the third question, please, Dr. Satish? Third question. Yeah. Third question, please. So the third question is, what is the cutoff limit for thickening fraction that suggests diaphragmatic weakness? Less than 20%, less than 40%, less than 60%, less than 70%. So you have 30 seconds to answer this question. All right. And we now the last question, Dr. Satish, last question, please. May I have the last question? And the last question is, which part of hemidiaphragm is used to measure diaphragmatic excursion during inspiration? Is it anterior third, middle third, posterior third, all of the above? So you have 30 seconds to answer this. All right. Thank you very much. We'll start with the presentation now. So, okay. Thank you very much, Dr. Nouri, for that kind introduction. The topic given to me today is basics of lung ultrasound. At the outset, I would like to thank the organizers of ASPA-FLEX for providing me this opportunity. Greetings to you all from my hospital, Ruby Hall Clinic. I have nothing to disclose. The photos and videos which I'll be showing are my own patients, and I have taken due permission from them. For the novice, I would like to recommend Point of Care Ultrasound book by Dr. Neelam Soni. The talk outline I'll be talking today is initially the principles of ultrasound, the basics of ultrasound, and then I'll be touching upon lung ultrasound per se. So what is ultrasound imaging like? When we place a probe on any body structure, we see black and white lines. This is two-dimensional mode. We do not know what is what. So sometimes we see black, white, and gray structures. These black structures are known as anechoic areas, and this can be like blood or fluid. White can be hyperechoic, which can be due to bone, pleura, or air. Gray is hypoechoic, which can be due to nerves or muscles. So what is ultrasound imaging? How we teach novice? So now everyone can see this diagram, Lee de Tour France. So what is this all about? Now I am bringing one area in front of you, and now you can appreciate that there is one bicycle and one person riding over it. So now we can understand that Lee de Tour France is nothing but cycle racing across France. So this is similar to ultrasound training. When we have any ultrasound image, we do not identify any structure. But now when we have faculty with us, they can tell us that this is an artery, this is first strip, this is brachial plexus, and then we start seeing those structures, and then with practice we can pick it up. So now what all probes are available? We have variety of probes with different footprints. Mainly they are divided into high frequency probe, which are meant for seeing superficial structures, And then there are low frequency probe, which are meant for seeing deeper structures. So there is something called as orientation marker, which is seen over the ultrasound probe, and it is also seen on the ultrasound screen. So we have to note it down, and when we place a probe over patient's body, we need to know which is medial, which is lateral, which is anterior, which is posterior. So with the help of ultrasound orientation marker, we can do that. So something about gain button, something about depth. So we have to adjust depth so that the structures of interest are in the middle of the screen. Then we can adjust with the gain button the overall brightness. And here you can see the first part is showing optimal gain, the middle is over gain, and the last is under gain. Something about ergonomics. Now, when we are doing ultrasound, we must make ourselves comfortable. As you can see here, the performer is sitting on a chair. Both the forearm, the elbow, the wrists are in relaxed position, and the ultrasound screen is in the front of the performer. So we should try and keep the ergonomics, we should plan it beforehand so that the success rate increases. What about Doppler? When we place ultrasound probe over any vascular structure, we see red or blue, and this is because of the direction of blood flow. So this is Doppler effect, the structures moving towards the transducer. When RBCs move towards the transducer, they are seen as red. When RBCs move away from the transducer, they are seen as blue. Now, are there any challenges with pediatric ultrasound, pediatric POCUS? Yes, there are challenges. The first and the foremost is babies just do not like the, the feeling of cold jelly, and they may tend to move. So you may have a moving structure and the challenges are more. The second challenge could be if we place the probe for a little longer duration, chances of hypothermia, and we have to look after maintenance of all aseptic precautions. So what are the POCUS applications? Now, POCUS is mainly used for minimizing the delay between the onset of symptom and initiation of definitive therapy. So we need not wait for radiologist or cardiologist or X-ray technician for narrowing down our differential diagnosis. So what are the situations? POCUS question is mainly designed to get answers in form of yes or no, like why my patient is desaturating, why my patient is hypotensive, or what are the reversible causes of tachypnea, tachycardia, cardiac arrest in my patients. So now coming to the basics of lung ultrasound, if we look at the history of lung ultrasound, it was by Professor Daniel Lankenstein and his pioneering work in late 1990s. As regards to indications of lung ultrasound, the pediatric lung POCUS is mainly used for confirmation of endotracheal tube to rule out endobronchial intubation. The second common use is used for detecting pneumothorax because of any cause, or to pick up lung water in form of cardiogenic pulmonary edema. And it is also useful for assessment of diaphragm in predicting length of hospital stay and plan for extubation. So in short, lung ultrasound is non-ionizing, cost-effective bedside interrogation. Is there any evidence? Yes, the evidence is substantial and it is in favor of lung ultrasound. So what are the limitations? From patient side, it could be morbid obesity, subcutaneous emphysema, surgical dressing. But other important aspects are limitations with training, credentialing, limited availability of ultrasound machines, and resistance from other specialties like radiology, cardiology, etc. So what about the lung evaluation area? Now, this was again first described and by Professor Lankenstein, that it is more or less similar to how we put our stethoscope first over the anterior aspect of chest, then on the lateral aspect, and then on the posterior aspect. So it can be anterior, lateral, and posterior. When we place it on the pediatric patient, we have to use linear probe. It can be anterior placement, posterior placement, lateral placement. It can be subdivided into upper and lower half. So how we do it? It is I aim. So first we have indication for POCUS. We have one POCUS question, and then it is image acquisition, then it is interpretation, then it is medical decision making. So this is point of care lung ultrasound. So how we do it is by pattern recognition. There are A lines, B lines, and we see lung sliding. So what are A lines? A lines are nothing but reverberation artifacts. So there is one pleural line, and just below that we see multiple parallel white lines. These are A lines. When we see A lines, it is indicative of normal lung. Now we need to know about lung sliding. We can see the pleural white line, the line which is white glistening and it is moving. This is normal lung sliding. If we cannot identify it, then we can put an M mode over that area if the movement is very subtle. And on M mode, what we see is the moving pleura, which is picked up as granular area, and the upper part, which is not moving. So it is something called as seashore sign. So if we see A lines and if we see normal lung sliding, then it is indicative of normal lung. So what is the differential diagnosis then for, say, if we do not get lung sliding or absent lung sliding, then the closer differential diagnosis can be pneumothorax, it can be pleurodesis, it can be loss of lung volume, or it can be reduced or absent lung ventilation because of apnea, severe laryngospasm, bronchospasm, endobronchial intubation, or sometimes when we put double lumen tube. So multiple causes. Presence of lung sliding definitely rules out pneumothorax with 100% specificity at the site of interrogation. What are B lines? B lines are pathological lines. They are hyperechoic vertical discrete lines. They start from pleura, move towards periphery, and they move with lung sliding. So here is one of our patient, premature baby with respiratory distress syndrome, and we can identify multiple B lines, which are laser-like lines starting from pleura going towards periphery. The newer machines are with auto B score, and these auto B lines will tell you the score in that area, and it is beneficial. So we can pick up interstitial syndrome when we have multiple B lines, when we have bilateral B lines in multiple interspaces, then it is interstitial syndrome. Presence of B lines does not necessarily means pulmonary edema. B lines do appear in various pathological lung conditions, like it can appear with pulmonary contusion, it can appear in consolidation, it can appear in non-cardiogenic pulmonary edema, ARDS, so on and so forth. What is Plapp's point? It is posterolateral alveolar pleural syndrome. It is very important because it is a highest yield area for picking up alveolar consolidation, atelectasis, and effusions. So if we can use either a linear or a curvilinear probe depending on the size of patient, or an echo probe, and we can pick up atelectasis and consolidation in this area. So little bit about diaphragmatic assessment. So we can be innovative when we do pediatric diaphragmatic assessment. Why? Because we can place the probe over sternum, and sternum is not ossified in pediatric population. So we can see bilateral diaphragmatic movement in one window. Here you can see the diaphragm is moving nicely, so it rules out endobronchial intubation and also tells us about the strength of diaphragm. So there is inspiration, expiration, inspiration, expiration. So we can assess it on M mode as well. So where to place the probe? So the probe is placed between the mid clavicular line and the anterior axillary line, and then we can put an M mode in the posterior aspect, posterior third of diaphragm. And what we see is inspiration, expiration, and we can actually put a caliper and see the difference. So this will tell us about the strength of diaphragm, and we can plan for extubation of these patients. We can predict length of hospital stay. Another important aspect is thickness of diaphragm. With inspiration, the thickness increases, and with expiration, it comes back to normal size. So where we do it, we place the ultrasound probe. It's a linear probe on the posterior axillary line. And what we see here is moving diaphragm. With inspiration, the size increases, and with expiration, it comes back to normal. So we can place an M mode and we can calculate the difference. So there is one formula for assessment. It is thickness at end inspiration minus thickness at end expiration upon thickness at end expiration. So if fraction is less than 20, then it can happen in various neurological conditions. So here the simple formula is like 36 minus 21 upon 21. So if fraction is less than 20, it is weak diaphragm. So various supporting articles for use of lung ultrasound in various surgeries, and they have looked at different age group of patients, and what they have found is the diaphragmatic assessment, the various points where they have looked for lung basic ultrasound, they found that results are correlating with the anthropometric measurement of the child, and results are reproducible. So in short, I have covered about basics of probes, then ergonomics, orientation marker, image optimization. We have seen indications, questions for POCUS, and I have covered about lung ultrasound basic with A line pattern, B line pattern, lung sliding, and diaphragmatic assessment. So last but not the least, clinical judgment is very important. Probe cannot replace it. My acknowledgements to my staff and my hospital, and thank you very much for kind attention. Yeah. So, Satish, Dr. Satish, if may I request you for poll results. So our first question was, which of the following is not the defining characteristic of B line? And the correct answer is D, which is given by 35% of the audience. B lines actually, they start from pleura and they go till far, they do not attenuate. So this is the characteristic of B line. May I have the second question, please? Second question. So the second question is, all are sonographic findings of lung except. So the answer here is the best answer of all four is B lines. B lines are pathological lines indicative of increased water content. May I have the third question, please? Third question. So the third question is, what is the cutoff limit for thickening fraction? And you have seen this in the presentation. It is less than 20%. And if it is less than 20%, then it is suggestive of weak diaphragm. May I have the fourth question, please? So the fourth question, and we have the polling result in front of us. So which part of hemidiaphragm is used to measure the diaphragmatic excursion during inspiration? So the correct answer is posterior third, because it is the thickest part of the diaphragm, which is confirmed on CT and MRI studies, and we should be putting M mode across the posterior third. I think that's all. Thank you very much. Thank you very much for patient listening.
Okay, thank you very much, Dr. Ahmed, for a nice introduction of a basic lung ultrasound. So if you have a questions or comments, please submit it to a Q&A box. And the chat function is disabled, so please use Q&A box. Okay, now we are moving on to the next speaker, Dr. Yi Ji-hyun. She is Clinical Associate Professor of Seoul National University, Republic of Korea. Her major is pediatric anesthesia, and she has special interests in use of ultrasound in pediatric anesthesia. She'll be talking about the advanced lung ultrasound. So Dr. E, please start your lecture whenever you are ready.
Thank you for the kind introduction. Hello, everyone. I'm Ji-hyun Lee from Seoul National University Hospital. It's an honor for me to give a presentation in 6th ASPA webinar. What I'm going to talk about this time is advanced lung ultrasound. I will show following cases, including atelectasis, consolidation, pneumonia, pneumothorax, pulmonary edema, pleural effusion, and COVID-19 patients with various images and videos. The most images and videos were from my patients, and for the others, the image sources were noted. The first is atelectasis. Lung atelectasis refers to collapse or incomplete expansion of pulmonary parenchyma. The image on the left side of the screen is subpleural atelectasis. As you can see, pleural line is irregular and hyperechoic as non-aerated tissue increase. Below the irregular pleural line, hyperechoic artifacts are shown like B lines, and sometimes this line is called the C line from consolidation. The video on the right is severe atelectasis. We can see the collapsed lung tissue and hyperechoic particles, which is air inside the lung. In operating room, this can be frequently seen after anesthesia induction. The anesthesia-induced atelectasis can be improved by applying recruitment maneuver. In this patient, ultrasound-guided recruitment maneuver in real time was done by increasing PEEP levels. You can see the pleural line become smooth, and amount of B lines are reduced. Next is the consolidation. Sometimes people use terms atelectasis and consolidation interchangeably. But atelectasis means collapse of lung, and consolidation is lung tissue that is filled with fluid or something other than air. It is usually seen in pneumonia or interstitial lung disease. But for lung ultrasound image, consolidation usually refers the tissue-like change in lung. The typical feature of consolidation is hepatization of lung, air bronchogram, and shred sign. Air bronchograms are hyperechoic lines and dots within hypoechoic area, thought to represent air trapped in small airways within a consolidation. Hepatization of lung refers change of lung tissue so that it resembles liver tissue. The shred sign appears when the border of aerated lung and consolidated lung is irregular like a torn paper. The brightness is because of the air, which scatters the ultrasound beams. Let's move on to the lung ultrasound image of pneumonia. The most specific sign for the diagnosis of pneumonia is the presence of air bronchograms. And air bronchograms are divided into two types, dynamic air bronchogram and static air bronchogram. If the bronchograms are mobile according to respiration, as you can see the videos, they are considered dynamic air bronchograms and are thought to be pathognomonic for pneumonia. If bronchograms are immobile, They then called static airborne programs, which can be seen in both atelectasis and pneumonia. Let's move on to the pneumothorax. The typical features of pneumothorax are absence of lung sliding, but the presence of lung point and barcode or stratosphere sign in M mode. The lung point sign is highly specific sign for pneumothorax. It is the point where visceral pleura begins to separate from the parietal pleura at the margin of pneumothorax. Barcode sign is uniformly parallel horizontal lines above and below the pleural lines due to lack of motion in the chest wall or lung in M mode. Let's move on to pulmonary edema. I'm sorry. In pulmonary edema patients, the pleural line is regular and smooth. B lines are evenly spread, laser-like artifacts spreading from the pleural line to the bottom of the screen. Ultrasound findings of pulmonary edema are different from that of atelectasis or consolidation, which usually shows unevenly spread B lines with irregular pleural line or consolidation. Now I'm going to show the pleural effusion and empyema. The effusion on the left image is anechoic and seen between visceral and parietal pleura. You can see the floating lung tissue within the effusion. In the presence of pleural fluid collection, the transmission of ultrasound waves is enhanced, allowing us to visualize the presence of the vertebral bodies. This is called positive spine sign. Dense echogenic patterns are most often associated with hemorrhagic effusion or empyema, as seen in the image on the right. This is lung ultrasound images from adult patients with fever, tachypnea, and general weakness. At the flaps point, the massive separated effusion was found. Loculated effusions occur most commonly in association with empyema, hemothorax, or tuberculosis. So what do you think it is? This lung ultrasound image was from a pediatric patient who received thoracoscopic surgery. Is there lung sliding? Yes, it is here. Is there lung point? It seems like lung point, but the point is not located in the same line of visceral pleura. So it is different from pneumothorax. This is subcutaneous emphysema. The air lies just below the skin in the subcutaneous tissue and obscures deeper structures in the chest wall. The intercostal muscles, ribs, and pleural surface are all hidden. A common mistake is to confuse the non-sliding subcutaneous air for pneumothorax. This is the simple algorithm for diagnosis of hypoxemia using lung ultrasound in operating room. When there is desaturation, the first action as anesthesiologist may be the auscultation, then ultrasound probe applied in dependent regions to rule out pleural effusion or atelectasis. And in anterior regions, check lung sliding sign and B lines. And when there is no lung sliding and B lines, but there is lung point with decreased lung sound, pneumothorax should be considered. Differential diagnosis can be done using B-line characteristics. Unilateral B-lines suggest pneumonia, and bilateral B-lines just suggest alveolar and interstitial lung disease with clinical correlation. Scoring lung ultrasound findings can be helpful to monitor and follow up the disease severity. This is a representative lung aeration scoring system in ventilated patients. Figure A is normal aeration, which is the presence of lung sliding with A lines or fewer than 2 isolated B lines. score is 0. Figure B is moderate loss of lung aeration with multiple and well-defined B lines. The score is 1. Figure C is severe loss of lung aeration with multiple coalescent B lines, and score is 2. And D is consolidated lung, and score is 3. The evaluation is performed in total 12 regions, so score is possible between 0 and 36. Now I'm gonna show a case. This 2-month-old baby underwent cardiac surgery due to complex heart disease immediately after birth. At postoperative day 1, central ECMO was inserted after CPR due to recurrent hypoxia and bradycardia. Then for a month, ECMO weaning has been tried several times, but failed every time due to lung condition. The right side image was chest X-ray, and total collapse of left lung and right upper lobe were found. So bedside bronchoscopic evaluation was requested. Before bronchoscopy, we performed lung ultrasound. In right upper lobe field, tissue-like structure without any aeration was observed, and this was consistent with total collapse. In right middle of field, lung sliding with B lines was found, suggesting ventilated lungs. This is the left lung ultrasound image. You can see the hepatization of lung and bronchogram inside of lung. The cardiac pulsation was observed, so the fiber optic bronchoscope was done. There is a lot of thick secretion and blood clots, so we performed massive suction and recruitment maneuver. Then follow-up lung ultrasound showed the ventilated area increased. And the left lung, the multiple coalescent B lines appear, attesting to penetration of gas within consolidation. Now, I'm going to talk about the lung ultrasound in COVID-19 patients. Lung ultrasound has become an important tool in diagnosis and follow-up of patients with COVID-19 because of its bedside feasibility, lack of radiation, and easy application. In addition, small handheld machines are easier to sanitize and protect with single-use plastic covers. Therefore, many clinicians evaluate the feasibility of lung ultrasound in COVID-19 patients recently. This is a nice protocol for protection and disinfection of ultrasound device in all patients with suspected or confirmed COVID-19. So you can download this guideline in the homepage. The important thing is drape the ultrasound machine with clean plastic covers or something like trash bag, and make sure to sanitize all part of a machine using disinfectant wipes after removing the covers. These are typical findings of lung ultrasound in adult COVID-19 patients was reported. At beginning of the lung involvement, B lines are distributed heterogeneously between spared regions of A lines. As disease progresses, lung density and the amount of B lines increase, leading to coalescence of artifacts into glass rockets and then white lung. In advanced disease, the lung density further increases with loss of aeration with or without pleural effusion. The light beam can be seen, which is hyperechoic artifact and also similar to white lung, but light beams usually arise from normal pleura. And this is become more severe. Lobar consolidation with air bronchograms can be seen. According to previous reports, 95 of COVID-19 patients had a predominance of lesions in the subpleural area. So lung ultrasound can be a key role in the early detection of these lung involvements because it easily identifies infections extending to the visceral pleura. Sonographic lung features in pediatric patients were similar to those described in adult reports. These are images from 11-year-old male with respiratory failure and shock. Lung ultrasound was performed on the 5th day after symptom onset and chest CT on the 15th day. There was a pleural effusion, which is PE in the figures, and subpleural consolidations stars in the figures. Confluent B lines were also present in the lung ultrasound, corresponding to CT, which showed bilateral GGO patterns. However, if you find the unilateral consolidation within the large pleural effusion, it would be bacterial pneumonia rather than COVID-19 pneumonia. The routine use of lung ultrasound in evaluation of children with suspected or confirmed The routine use of lung ultrasound in the evaluation of children with suspected or confirmed COVID-19 may be a useful tool in diagnosing and monitoring COVID-19 pneumonia. However, lung ultrasound has some limitations that are inability to visualize centrally located consolidation, inability to differentiate consolidation from atelectasis, and possibly some degree of overdiagnosis, as ultrasound can detect even small consolidations of unlikely significance. So lung ultrasound in COVID-19 patients should be performed by experts who received advanced lung ultrasound training specially for this purpose. This is the last slide. Now I'd like to conclude this lecture. Lung ultrasound is a highly sensitive tool and have some advantages for diagnosing various diseases compared to chest X-ray or CT. There are some considerations. First, there are inter-observer and intra-observer bias in performing lung ultrasound and interpreting images, so continuous and formal training are required. In addition, there are non-specific patterns in lung ultrasound findings. For example, B lines can be seen in various kinds of conditions. So point of lung ultrasound cannot be used as a sole diagnostic tool, but it is recommended as a clinical and diagnostic complementary and monitoring tool. Thank you for listening. Please feel free to contact me if you have any questions after webinar. Thank you.
Thank you, Dr. Lee. Our next speaker is the President of the Academy of Regional Anesthesia, India. She is also the program head of the WFSA Pediatric Regional Anesthesia Fellowship in Mumbai, India. She has several publications in international journals on her interest in regional anesthesia with ultrasound guidance. Please welcome Dr. Vrushali Ponde.
Namaste and welcome to today's topic. Well, we are now going to look at the ultrasound application to airway and gastric antrum. To begin with, I would want you to read this sentence. Rather, there are 2-3 sentences. I wouldn't want you to really ponder upon the spell checks, simply read. And I'm sure you are able to read right now, simply because, look, our brains are actually pretty much conditioned to read the first and the last letter, and hence we can read the entire sentence pretty clearly, even though there are a lot of spelling mistakes. The point here to tell you is there are patterns, and patterns form conditions in our brain, and this is how we decipher a lot of things, and ultrasound is no exception. This is what Amit had showed you. There was a bicycle in him, and these are certain sentences with a lot of spell errors, but yet you could go ahead deciphering them. So we are now going to apply ultrasound beam on the airway and see what information it can give in our daily practice. To understand this, let's start with understanding the equipment. After then, we would go ahead to decipher the transverse sonoanatomy of the airway, then the longitudinal sonoanatomy of the airway, and the clinical applications of it. It could be any probe, but it has to be a linear probe. Any company, but linear probe. If the baby is very small, a hockey stick probe, which is slightly wee bit expensive than the others, can also be used. But mind you, any high frequency linear probe is good enough to read ultrasound. The neck could be boggy, the neck could be very small, the neck could be extremely toned and well, but any which ways, a high frequency probe is what is required to understand and read ultrasound neck. We have to come to proper understanding of what is the concept behind so that we can build up the entire scene very easily in front of us. The concept is very, very simple, and it goes as follows. Airway as such has one bone and two cartilages, which is thyroid and cricoid, and of course then the tracheal rings, which also are cartilages. So we have one bone following by a lot of cartilages, and of course the membranes in between and the soft tissues in between, and the air, never miss that. Altogether, they are going to form an architecture which is very, very easy to decipher, and let's go about doing that. We can do, as I said, in a transverse scan and a longitudinal scan. Note this picture here with the footprint properly placed on the neck of the child, but it is a child here. If it was an infant, maybe a smaller footprint probe could have been helpful. Footprint of the probe is that part of the probe which comes in contact with the skin. So now we shall ponder a little more on the longitudinal section of the neck. Well, the green bar which is here, which actually is spanning from the thyroid cartilage till the tracheal cartilages, or rather the trachea, we shall try and see it and understand in this particular ultrasound image. Before even reading anything in the ultrasound image, try and understand where is the orientation marker. In other words, the blue-green dot. Here, the blue-green dot is pointing towards the cephalad or the head end of the patient. No matter where you keep it, we need to be mindful of where it is so that we can anchor our scans well. So this is the head end of the patient, and this is the foot end of the patient. This is the anterior of the neck, and this is the posterior of the neck. To begin with now, let's start reading layer by layer. So this is the skin and subcute, understandably very, very thin. And this is the thyroid cartilage. Now, thyroid cartilage, being a cartilage, is not ossified and is showing everything underneath. This is one, thyroid cartilage, second, cricoid cartilage, and all these are the tracheal rings. Having said this, please do not miss the air mucosal interface, which is a bright, hyperechoic line staring at you. Also, do not miss the air artifacts, which are reverberation artifacts actually, and the presence and absence of it matter. We shall soon see how in the next couple of slides, because ultrasound, even artifacts in the ultrasound actually can be very, very helpful in our day-to-day work. Let's recapitulate. Now, this is the thyroid, this is the cricoid. So the soft tissue in between, particularly this area, is actually the cricothyroid membrane. In an emergency, this is where we would want to put our needles to get the access through the cricothyroid membrane. Coming to the bone, the transverse scan rather, and we are going to slide the probe from the hyoid lower down. So to begin with, we shall look at the hyoid bone in the transverse section. Please note I said bone, so this is the bone. This is the anterior, this is the posterior of the neck, skin and subcutaneous tissue, and this is the bone. Bone being itself, it isn't showing anything underneath, so this is the hyoid bone. Now coming, we have slided the probe down to the thyroid cartilage here, and this would be the thyroid cartilage. Now, this is the skin and subcutaneous tissue. These are the strap muscles, and this V-shaped character is the thyroid cartilage. You could see that these are the vocal cords, the true vocal cords. Something here in between would be the false vocal cords, and these are the arytenoid cartilages. So this is the thyroid cartilage. I don't know if there is any way to remember it. Maybe this is Roshali who's speaking to you. Invert my first letter and this becomes thyroid, a V-shaped thyroid. And the vocal cords here are always seen. And once you see the dynamic scan of it, which you shall see very soon, it would move very well towards each other. And that again gives us a lot of scope to diagnose few things. Now, when we come to slide the probe even lower down in the neck, then we are going to see the cricoid inverted C-shaped cartilage here. Let's read one by one. Skin and subcutaneous tissue, the strap muscles here, the cricoid horseshoe-shaped cartilage. And now you will see the air mucosal interface, and below it, the reverberations artifacts due to the air inside. Let's go even lower down. Let's slide the probe lower down, and we are going to see the tracheal rings. Now, how do we really understand that these are the tracheal rings? Well, let's read the scan. Skin, subcutaneous tissue, the strap muscles. Now what has appeared is the isthmus of the thyroid gland as such. Now this is the tracheal ring as such, or the cartilage as such, and this is the air mucosal interface along with its artifacts. If we really take a proper look on both the sides, you will see that the thyroid lobes have appeared. So cricoid is also an inverted C. Thyroid is also, trachea is also an inverted C. But now atop the trachea is the isthmus of the thyroid, and on both the sides, it is hugged by the thyroid lobe. On the left side, always think and look for the esophagus. So this is the esophagus in the corner of the trachea on the left side, and below it, in fact, is the transverse process. In between them would be the longus colli muscle. Well, now, if you really ponder on this, where does our maneuver of putting the pressure on the trachea really helps? You might now think that the esophagus is right on the left side. So how does it compress? We compress on the cricoid, and hence that maneuver helps us. Now coming to a panoramic view so that we get a clear idea as to how we really look at the ultrasound of airway at the level of the trachea. So to begin with, this is the anterior and this is the posterior, the skin subcutaneous tissue, and this is the trachea here. This is the thyroid along with its lobe. This is the carotid artery. This is the IJV, and that's the esophagus. So this is what a panorama would look like. Now coming to the clinical applications, because anything that we learn, we must be able to apply to the everyday practice, and we must be able to tell ourselves that is it giving us any more advantage than what we already used. So now we are going to look at esophageal intubations and how better this modality could be to understand them. We could look at the tracheal intubations, and we could look at the tube sizes as well. So let's come to one by one. Now here again, this is the trachea and this is the esophagus. Traditionally, and even today, every day, how do we intubate and how do we confirm that the tube is where it should be? A tracheal intubation is confirmed first reflexly by the chest rise, auscultation, and of course the hallmark, the gold standard, the ETCO2. This can be done now, even before the tube has actually gone and lodged inside. It can be done right during its transition inside. So if one anesthesiologist can place the probe transversely onto the trachea, without compressing it much so that you don't become a nuisance to the person who's actually intubating. You could go like this. So this was what the trachea is, and this is the esophagus here. This is the esophagus which is collapsed and now shall host the tube, and you get a double tracheal sign. So these are two tracheas. The moment you see two tracheas, you're in the esophagus. Before the chest rises, before you even attach the circuit and understand where the air is going, you know where it is. Now, this was a dilatation due to the tracheal dilatation due to a cuff that is inflated, telling you that the tube is there. Well, coming to again confirmation that the tube really is inside the trachea. Look now, this is anechoic, and the reverberation artifacts, which were pretty bizarre, are now gone away. And you see two straight lines. One is the air mucosal interface, and another is due to the endotracheal tube placement. Another way of seeing endotracheal tube placement is this way: a clear cut two signs, two bright signs, one of air mucosal interface and another of the endotracheal tube itself are staring at you. In the longitudinal way, you would see this two long is equal to sign, one of the air mucosal artifact and another the tube itself. Now, coming to tube size, we have a very nice paper written from CMC Vellore, India. What they have done is, in the subglottic area, they have taken the minimum transverse diameter and they have measured it, and that has correlated pretty well for the tube size that they used. And it was better than the formulas. It did better than the formulas that are available. And well, there are many other references to the same. Now, if you really see at this video, you will see that the tracheal walls are abutting against each other. So this is kind of a collapsing trachea, tracheomalacia. So you can diagnose the condition right this way. Well, the video that is going to get opened in front of you is going to show you a perfectly orchestrated movement of the vocal cords, and they would be so harmonious with each other that you would know instinctively that there is no palsy or there are no paralysis of the vocal cords. I leave the video to you a bit so that you really decipher what I am trying to tell you. So the movements are pretty symmetrical. Well, now the potentials are lots. We have just shown you the glimpse of what is possible. Now let me just share you the entire scope of it. Prediction of difficult airway, confirmation of proper endotracheal tube, evaluation of airway pathologies that may affect the management, prediction of obstructive sleep apnea, prediction of the size of endotracheal, endobronchial tubes, airway-related nerve blocks, assessing and guidance of proper percutaneous dilatation tracheostomies, and assessment of vocal cord movements. All this is possible with ultrasound by your side when you deal with airways. Coming to the next part, which is vitally important for anesthesiologists. Are our children really fasting, especially in scenarios where we do not know the history? Or if at all we are in a situation to go ahead, how much is the content and what kind of content are we dealing with is the question that we may get answers from gastric ultrasound, and let's see how. Well, the equipment, the scanning technique, the actual sonoanatomy and the clinical applications is something that we are going to look at. We need a linear probe to look at the gastric antrum of small babies, but when they grow up and in adolescence, obviously we need a low frequency curvilinear probe because we need better penetration. So this is about the equipment. Now we shall see the scanning technique. Before that, again, let's pause and spend a minute over the anatomy so that we know what sonoanatomy to expect. From the skin and subcutaneous tissue onwards, what we are going to really see is the liver. Then we are going to see the gastric antrum. Then we are going to see the pancreas. And of course, around it is going to be the aorta and the superior mesenteric artery. So watch out for these few simple structures. And it's really very simple. If you understand the anatomy, ultrasound is really very simple. How do we really scan, and where do we put the probe so that that simple anatomy reveals itself to us? Two positions are required. One is the supine with the orientation marker cephalad. It could be the other way around as long as we are mindful of it. So this is one way. Now, where do we keep the probe is just underneath the Ziffy sternum. And we need to check the same thing in the lateral position as well. So now, what is the real thought process of doing it? We should be starting actually just the way it is shown here. This is the probe, and then we just need to slide it on the other side of the midline, the right side of the midline. And if you see the schematic diagram here, this is the gastric antrum, and this is the liver. And we are going to see obviously something more posterior to it as well with the ultrasound. So in nutshell, supine and lateral, and now we know how to scan. So once we see it in the supine position with the orientation marker cephalad, then this is what we start seeing. We see the skin and the subcutaneous tissue, which is again thin. We see the rectus muscle. We see a big liver, which a biggest portion is the liver, which we will never be able to miss. We see the bowels. We see the pancreas. We see the aorta, the superior mesenteric artery. And of course, then we see the gastric antrum. The lips here are actually closed. And this is an empty stomach, an empty antrum. It won't look the same when it is filled. And it won't look and what is filled inside will never look the same when the material is different. So let's look at that. Now, this is one case where actually the gastric antrum is pretty close and kind of coming on, the lips are again coming on each other. But when the same child was actually turned supine, turned lateral from the supine is what I meant. The antrum actually opened up. So this is a closed antrum in supine and an opened up antrum in lateral. And this is again a mixed picture, but it looks more like fluid. So nature of the contents and appropriate fasting can be answered. And let's understand what the nature, which content is going to put up what kind of an ecogenicity. So an empty stomach is not going to show us anything. Small amount might be still seen as hypoechoic shadows. Clear fluid is going to be hypoechoic. Solid is going to be heterogeneous, particulate, mixed with air sometimes. And maybe that is why the heterogeneous structure is seen, because we chew while we chew, we really chew a lot of air along and then swallow it. Milk suspensions is going to be hyperechoic again, because milk solidifies a lot. So this is all about gastric antrum. A lot can be done here. We can go to quantitative and qualitative assessments. There are formulas, but I wanted to give you a glimpse of it so that we can really start implementing it in our day-to-day work. Thank you very much for attending ASPA-FLEX, and thank you very much for listening to this.
Thank you very much, Dr. Bruciali, for your very comprehensive lecture. I would like to remind our participants that the chat box is disabled. So for your questions, please type them in the Q&A box. It is open, and your questions will be answered. For our last speaker for today, he is joining us from Boston Children's Hospital in Boston, Massachusetts, USA, where he is a senior associate in cardiac anesthesia. He is also an associate professor of anesthesia at the Harvard Medical School. Colleagues, please welcome Dr. Koichi Yuki.
Thank you very much for kind introduction. I'll talk about point-of-care ultrasound today. So as many speakers talked about, there's many indications for point-of-care ultrasound, and there's many different probes. So we have to choose the probes that appropriate for indication. So largely probe can be divided into three: linear probe, curvilinear probe, and the phase array probe. For the cardiac ultrasound, we primarily use a cardiac phase array probe, which has a beam coming from narrow spectrum, and then shows a fan fashion. Oftentimes, its frequency is very low, so that they can penetrate the deeper tissue. For the reference, for the curvilinear probe, which had its wider beam coming in a fan fashion with the low frequency, so it's oftentimes used for the normal probe. And then for the linear probe, which had a beam coming from that many different surfaces with in parallel with the high frequency, so it's actually captures a very shallow structure, oftentimes used for the vascular probe. Today, I will talk about the cardiac ultrasound from the transthoracic view, primary focus on the apical, peristernal, and subcostal view, and also share some scenario of the hypotension. First of all, it's important to understand the orientation of the heart in the thorax, in the chest. So to the right side panel, you can see that's the sternum with the rib cage, and underneath the sternum, you see that aorta in the right ventricle. To the left, to the sternum, you see the left ventricle and part of the pulmonary artery. To the right, to the sternum, you have the right atrium. Heart is actually located a little bit oblique compared to the center of the axis in the body. So you see on the left side panels, there is a 60 degrees in general from the horizontal plane in terms of the axis in the heart. Today, again, talk about this three view, peristernal view, which is an A, and you can actually place the probe left to the sternum, oftentimes the third and fourth intercostal space, or B, apical view, which you're looking for the maximum impulse on the heart, and looking at the four chambers, and C, subcostal view, which will put the probe underneath the sternum through the abdomen to the liver and looking at the heart, which actually from the right side structure. This is a rough idea how you can capture or what kind of structure you can get from the individual views. So apical view, you can see that the right and left ventricle as well as right atrium and the left atrium. And you also see that's the AV valve. So it's in generally good to looking at the bilateral structures. Peristernal long axis view, you can see that the left ventricle as well as left atrium, aortic valve and mitral valve. So it's generally good for left side structures. Peristernal short axis, you see on the panel on the right, you see that the aortic valve in the middle and the right ventricular outflow tracts wrapped around. So in generally good to looking for right side structures. So first I'm going through the apical view. Again, we're looking for the maximum impulse. Oftentimes we ask the patient to left side down so the lung can actually fall down with the gravity so you can have a good window for the heart. Transducer can be pointing to the right side shoulder. And again, it is good for looking at the four chambers, which is shown in that panel 2. Once you get to the fourth chamber, you can try to bring the probe up and down relative with the patient front to back. So if you bring the probe toward the patient front, you start cutting that aortic valve and the aorta, which is shown in the panel 1. If you bring that probe backward towards the patient back, you'll start cutting the coronary sinus. This is just a simple imaging of the four-chamber view. Next, for the peristernal view, you're looking for third or fourth intercostal space. And again, you might want a patient to be a left side, left lateral decrease position so the lung can fall down and get the good pictures. For the peristernal long axis view, you might want to orient the transducer pointing towards your right shoulder. And again, I mentioned that this is actually good to looking for left side structure. And the image 2 shows that you have left ventricle, as well as left atrium, mitral valve, aortic valve, and aorta. When you bring that probe to the right side of the patient, you start cutting more in the right side structure. So you'll see that RV as well as the right atrium. When you bring the probe to the patient left, you start cutting that right ventricular outflow tract because pulmonary artery is next to the aorta. So you see that right ventricle as well as pulmonary valve and the pulmonary arteries. Also, it's important to know that you can actually see that the descending aorta, which is actually good to notice to differentiate the pleural effusion versus the pericardial effusion, which we're going to go to a later slide. This is just imaging of the normal heart, 11 years old. Now moving on to posternal short axis view. So once you obtain the posternal long axis view, you can do 90 degrees clockwise rotation from the position of the posternal long axis view. And you can see that the wraparound view, which I showed in the previous slide, in this case, panel 1, you see that the aortic valve in the middle, and then you see left atrium, right atrium, and tricuspid valve, right ventricle, and the pulmonary valve. You bring that probe downwards, patient the foot, you start cutting the mitral valve. So you see that anterior and posterior leaflet and mitral valve, which is shown in panel 2. And further down, bring the probe down to the patient foot. You start cutting that papillary muscle. You see that anterior and posterior papillary muscles. This is the imaging of the short axis view at the mitral level. So you see that the anterior and posterior leaflet is moving well. And this is a view of the papillary muscle level. So you see that anterior and posterior papillary muscle. Now we're going to go over the subcostal view. Again, the probe is actually going through the abdomen. So you'll cut the liver and you're looking at the heart from the right side structures. This is actually a good view in the setting of the trauma because it's away from the airway and neck and chest procedures. And also because it goes to the liver, not through the lung, so it might be relatively easier to obtain. In terms of volume studies, you might try to looking for IBC and compare the diameter in interior and external phase, or you can ask the patient to sniff to increase its interthoracic pressure to see whether or not there is a possibility, which is maybe good to assess the volume status. So first from the subcostal long axis view, again, you're looking at the heart from the right side structure. And so in the panel 2, you see that right ventricle, right atrium and tricuspid valve, and the left ventricle. In this case, you also cutting at the aortic valve and aorta. You bring the probe towards the patient back, you're starting cutting at the left ventricle and the left atrium, and you see the pulmonary vein coming into it. When you bring the probe upwards, patient front, you're starting cutting a right ventricular outflow tract. So you see that RV, pulmonary valve, and then pulmonary arteries. This is just sweep view. So you'll see that probe coming from the back of the patient and then coming to the front. So you see that the left side structures, and you see that the aortic valve and the aorta. And then you start seeing more in the right, RV. Now we're going to go over the subcostal short axis view. So you bring the probe like clockwise, and you're cutting that LB and RB, which is showing the panel 4, and you start sweeping the probe, as you see on this image. In this panel 3, you see that mitral valve and right ventricular outflow tract. And then further sweep to the panel 2, you start seeing the aortic valve and aorta. And further to the right, you start seeing the right atrium, SVC as well IVC. And next video is going to show that panel 4 to 2, Yes, so you see that's LV and RV. And then start seeing that's aortic valve and aorta. In terms of IVC view, so it's important to know the location. Dr. Burchari actually went through that gastric ultrasound and go over this actually anatomy, but I'm just going to show again that the aorta and the IVC orientation. IVC goes connect to that atrium, and the liver is over it. It can be obtained by the Cabrini probe, but I'm just going to show the phase array probe imaging. So this is IVC and the right atrium. And also, it's probably important to get the imaging of the inspiratory as well as expiratory. So see whether or not how the diameter change with the respiratory patterns. I'm going to go over a few scenarios of unexplained hypotension. So when you encounter that hypotension, it's important to notice it is actually that's a preload issue or it's a pump issue or afterload. For example, if you have that poor ventricular function, it's a cardiogenic shock, and that might actually show as a very poor ventricular functions on that ultrasound. Hypovolemia can be observed when you actually try to looking for IVC size. Also, we can actually assess by the ventricular chamber size. Right ventricular strain can be also important sign in the setting of the pulmonary embolus or air embolus or other reason for the pulmonary hypertension. And also, you might actually encounter a situation where a patient has a cardiac tamponage. There is many different algorithms being published. Nonetheless, I think it's important to try to looking for pump function, preload and afterload, and in the conjunction with the clinical scenarios. In terms of hypovolemia, again, you can see as a small chamber filling size. And in the case of the hypovolemia, you might see that ventricular wall motion is very aggressive and also maybe like kissing each other's. IVC diameter can be obtained with the inspiratory and expiratory. And you might see that it's a flat IVC with a decent inspiration. In terms of pericardial effusion, most common finding is a chest discomfort, but patient may present as a dyspnea, cough, fatigue, or sometimes a nausea and vomiting. However, it's a pericardial effusion that accumulates over time with over a long duration. Patient can be asymptomatic. There is other cause for echo free space other than the pericardial effusion. So it's important to notice whether or not there is a pleural effusion or epicardial fat. If in the case of epicardial fat, it's often accumulates only at the anterior AV glute. Other rare causes can be cyst or dilated pulmonary arteries. This is just imaging of pericardial effusion, and effusion shows in the star from the different views. So you see that the fluid accumulation around the heart. I mentioned that it's important to differentiate pericardial effusion versus pleural effusion. So when looking at the peristernal view, you might be able to see the descending aorta. And if you see that the fluid correction above the descending aorta, which is above the pericardium, you can see that's a pericardial effusion. However, it's a collection behind it. It's oftentimes a pleural effusion. So this is actually a good image to distinguish both two. Also, you might see the collapse of the some of the heart chamber. For example, right atrium is a low pressure system, so you oftentimes encounter the collapse in the right atrium. Also, the ventricle in the diastole is turned to be low pressure, so you might see that right ventricular collapse in diastole in the setting with a pericardial effusion. This is an imaging of pericardial effusion in one of the patients. You also see that the fluid correction around the heart. Also, if you try to looking for inflow gradient through the mitral valve, you might actually able to diagnose a pulsus paradoxus. So there is a change of expiratory and inspiratory in terms of gradient through the mitral valve. If you have a gradient more than 20, which sort of indicate that the patient has a pulsus paradoxus. This is one of the examples that we had in our institution was accidental air injection to the patient, and the ventricle was completely opacified with the air, which showing the panel A. And after the few minutes, in this case, 4 minutes, you see that the right ventricle is cleared up. Eventually, patient did well, but this is something actually we kind of had at the event. So here, lastly, I'm just going to finish with the poll question. So what is a common probe used for transthoracic cardiac ultrasound? Would you mind bring that poll question, please? So you have 30 seconds to answer. A is a linear probe, B, curvilinear probe, C is phase array probe. Okay, I think it's probably most of the people answer the question. So it look like most people chosen that's a phase array probe. And yes, so answer is yes, phase array probe, which we went over. Okay. And the linear probe is for vascular, and the curvilinear is oftentimes used for abdominal ultrasound. So second question, please. So what is the structure suggested by arrows? So you see that structure here pointing by arrow. A is a descending aorta, B is coronary sinus, C is pulmonary arteries. Okay. I think most of the people seem to answer the question. So I'm just going to go to answer. So question is A, descending aorta. Coronary sinus is very close, but I think in this case, arrow is pointing towards the ear, descending aorta. And the circle above is probably the coronary sinus. Again, thank you very much for attention, and thank you very much for this opportunity.
Thank you, Dr. Koichi, for your very informative and comprehensive lecture. Thank you.
Thank you for all our precious speakers. Your talks were very comprehensive. And we have some questions. Some of them have been answered, but I will ask them again. One question is, in an intubated patient during a laparotomy, what view can I try to obtain standing at the head end and again after dressing has been applied to find the volume status? Maybe Vurushali may help us.
Yes, if the dressing has already been done, and if it's a tegaderm dressing, then we can still go atop the dressing. That wouldn't bother us. But if it is a lower abdominal incision and the dressing has is in the lower abdomen, nothing stops us from scanning just below the xiphisternum or at the level of xiphisternum. I don't think the dressings would come higher up. Or then you can temporarily remove the dressing and reapply it again. If dressing is an issue, I haven't yet understood what exactly is the issue. If they can,
maybe they can ask again.
Yes.
More clearly. And also there's another.
In fact, Sarpil, what I would love to add here is you can actually do this even while the operation is going on in very small kids, because sometimes when they are working, they somehow find that the stomach is still a little, they could compress the stomach even further. So we try and we try and aspirate, but if nothing works, we try and insert another infant feeding tube. And if still that doesn't work, we try and even see at that time, just sliding the probe through the drapes to see where they are, or certain surgeons can put their hand up and just feel for the RT. So it can be done intraoperatively as long as you know how not to go in the sterile areas. Because no matter where the probe you keep, you're going to see the image outside. So it should never bother.
Another question, can I use a curvilinear probe for subcostal view?
Subcostal view of Koichi, is it?
Koichi, maybe?
Yeah, sure. I mean, I think it's technically speaking, you probably can use an C. So it's actually give you like wider, actually the beam coming from. So it might be quite different from the typical views that you see in the ultrasound, but I think a curvilinear probe can be used. But again, I think a starting point of the window is probably, I guess, wider than rather than coming from one point.
And Koichi Sensei, another someone is asking about the reference IVC diameter size, pediatric or neonatal patients.
So I think there is I guess, a paper document in the cardiology literature about IVC diameter on the different age group, I think. But again, it's a very probably difficult to really measure because you know that the small patients have a very narrow diameter. So I think it's depending on how you're cutting the image, your diameter can be quite different. If you're purely just assessing that the volume studies, I think it's people are documented just comparison of your inspiratory and expiratory diameters, and you know whether or not like 50% reduction is probably one of the sensitive marker. The other thing is comparison is aorta to the IVC diameter. To see whether or not it's actually changed. But I think it's, if you're just purely looking at the volume studies, I think those are information to tell you, potentially suggesting the volume studies, but also you probably need to use a clinical scenario as well as you know, your intervention, the giving volume, see actually that improves the patient clinical status. So I think this is probably you have to use as a judgment along with some information from the ultrasound.
May I have a small comment? Yes. May I make one comment, please?
Yes, yes, please.
Yeah. So there was this previous question about the dressing being applied in the subcostal area, and again the assessment of IVC in small babies. So there are 2-3 ways of assessment. I think Dr. Koichi can correct me. One is IVC, second is we can sometimes look at cardiac output as well. So we can have an apical 5-chamber view where we can calculate VTI, velocity time integral, and LVOT diameter. So at least we can use that area to calculate cardiac output, and then we can give fluid challenge to the baby, and we can actually you know, monitor the hypovolemia that way. Dr. Koichi?
Yeah. I think it's, again, you know, it's important to put the context in the clinical scenario with, I guess, the treatment. See, actually, that fits on their actual diagnosis.
Yeah.
Again, we have other questions. One is there a sign for laryngospasm for pediatric patients during emergence in operating room? He's trying to ask, can we evaluate or assess laryngospasm with ultrasound imaging before extubation? Maybe Urushali?
Before extubation, well, I don't think I'm aware of any such signs. I don't think so that it is possible. After extubation, yes, it does become a very, very clinical scenario. Maybe if after the laryngospasm has been resolved, yes, that is the time we can see that the cords are open. We can reassure ourselves for the treatment, but I'm not sure at that time we can put in a probe and try and see whether it's a laryngospasm. It's such a clinical diagnosis is what I would say. Anybody wants to add on this?
Yes, I can. Dr. Brushali is adding on the laryngeal aspect. Also, we can place the probe lower down over the lung, and if there is no lung sliding sign, or if there are no A lines, probably there is no air entry going down. So this can give us some idea that patient is not getting ventilated. And instead of using stethoscope, we can actually place a probe, and putting an M mode app, we are able to see that ventilation is not happening. Uh, of course, clinical signs like with laryngospasm, the saturation goes down very fast. When it is bronchospasm, then it goes down slowly. It provides us time to settle with our clinical judgment, and then we can probably think over it. If we can also rule out if there are any other issues, just like pneumothorax, or what is the cause? Is it really laryngospasm or something else? So putting a probe over the basis of both lungs is a good idea.
You know what, Sarpil, there is a pediatric anesthesiologist in me which is trying to ask this question to the person who's asked this question. When you are trying to assess laryngospasm with the probe on the neck, if you are very sure it's a laryngospasm, and it wouldn't take much for you to understand that it's a laryngospasm, I don't think it will give you enough time for ultrasound. I think there and then, please go and rectify the laryngospasm, and then think of assessing it, whether it has opened up, is my clear answer to you. Yeah, but if it's a bronchospasm, if you don't know the cause of drop in saturation, then yes, one of you, and if you're very proficient with ultrasound, pick up your probe and search for answers. But till you get that proficiency with the probe, stick to your clinical judgments, introduce ultrasound in yourself, and let it be your second eye or second mind or whatever, and then use it in emergency situations.
Thank you, Urshali. Now we have some few questions as well. I think our speakers will answer them lately and mail to the who asked the questions. We have to finish our webinar today, so please do not forget to follow our webinar, which will be online in our website, in our Facebook and YouTube after this week. And certificate of attendances will be automatically generated and forwarded to those who will submit a post-webinar survey, which will be sent today to you. Please ensure that you have correctly keyed in your full name and emails. And also, please do not forget to join our next webinar, which will be on 17th of January in the new year. Hope this new year will be better than the one we had passed. Our subject will be minimally invasive surgery in neonates, infants, and children. Then also we have very brilliant speakers as well. Thank you for attending.
Thank you.